Just connecting. All right. Well, welcome everyone to this month's journal club for the London's Air Ambulance. And today we're going to be doing something a little bit different than normal. So we have two papers as opposed to just one. Typically, we look at a single paper and then discuss it. But for combinations of reasons, including the fact that these two papers were quite similar, as well as the fact that Luca said he had a great paper about ketamine he wanted to discuss, and I said, "Oh yeah, I've read that paper. Let's discuss it." But there were two great papers about ketamine recently, so we ended up doing both of them. So what I thought we would do is Luca's going to go through and lead us through the critical appraisal of both, and then at the end of the paper, two papers, we'll talk about sort of methodologic issues with the two papers first, and what the papers sort of what the results are. But I think if possible, people can hold sort of, we're going to have a more broad discussion at the end about the two papers in conjunction and what it tells us about about ketamine and implications for our practice and future steps and things like that. So we are lucky to have with us also Bob Larson, who, and potentially some of the other authors of the systematic review from our Scandinavian colleagues joining us for this journal club. So we'll have some expert input at the end of their thoughts and views and next steps. So I'll stop talking now. Just a reminder to keep yourself muted, please, if you're not speaking or asking a question, and I'll hand over to Luca.
Thank you very much, Michael, and welcome everyone. Good afternoon. My name is Luca. I'm one of the current HAMS registrar at London's Air Ambulance, and I will present you today's journal club, which we entitled "Ketamine Controversies: Can Too Much of a Good Thing Be Bad?" Just a quick introduction, very briefly. So ketamine is definitely a molecule I think many of us encounter fairly frequently during your daily clinical practice. Just to recall quickly, ketamine is an N-methyl D-aspartate receptor blocker that can produce analgesia, anesthesia, or sedation, depending on the dosage at which it is used. And this is why this molecule, which seems to be very versatile, is very attractive for the pre-hospital environment. Another of the, let's say, textbooks, pharmacology textbooks, things that makes it very attractive, it is that can be given via different routes. It can be given via the intramuscular, intranasal, intraosseous, and intravenous routes, and also technically oral. And usually it is not linked, historically it's not been linked with, at least from a textbook's perspective, it's not being linked with respiratory depression, which many other anesthetics drugs are. But we're going to discuss a couple of papers now, looking at the technical and methodological aspects, but also at seeing what were the side benefits and side effects of this drug applied to pre-hospital care. Two papers. One paper talks at ketamine used as sedation in a specific field of use of sedation, of pre-hospital sedation, and the other one talks about ketamine used as an analgesic, and different dosages, different applications of the drug. So the first paper we're going to discuss, it's rescue intubation in the emergency department after pre-hospital ketamine administration for agitation. It's an original research. It's an American paper. It's been published fairly recently. It's been published in December 2020 in Prehospital and Disaster Medicine, which is a journal focusing mostly on pre-hospital care, and mostly on disaster medicine. I will skip basically the background, the introduction to the paper itself. I will move directly on the paper outcomes as described by the authors, and then to the methods as described by the authors. So this is a study in which the authors declare the outcome to be the need for airway interventions with intubations following pre-hospital administration of ketamine for agitation in the pre-hospital settings. So we're talking about rescue maneuvers for the airway following the use of a sedation dose of ketamine. Their primary outcome is basically counting how many airway intubation events happen following the administration of sedative ketamine for agitations. And they add it additionally, they will monitor they will count basically airway intervention that include supplemental oxygen administrations, need for airway suction, in placement of an OPA or an MPA, and placement of a supraglottic airway. Secondarily, they will also take into account secondary outcome patients' dispositions from the emergency department, so the admit, discharge, or transfer of these patients. This is a retrospective cohort study. So basically, they start at a time point in time and they interrogate some sort of registry. We'll see which registry, for cases that have already happened in the past. So they define a time frame, they choose a cohort, and they go back in time to include patients. And this is a retrospective study. Their inclusion criteria is including patients who received prehospital ketamine for agitation. So there's a specific indication for ketamine administration in these methods. And basically, there's a predefined catchment area, which is that of 2 community ED in North America. So this is a North American-based paper in a paramedic-based, fire-based EMS system, where there are standing orders for paramedics to operate. And one thing that I find interesting here is that paramedics, according to the paper, commonly administer ketamine at a standardized dose of 400 milligram IM or 200 milligram IV, which seems very much to me, especially if we're talking about sedations. But this is actually what's in the paper, so I wondered if that was a typo or not. With the ability to repeat the dose once they're needed. I will try to give you the main aspects of the paper. Of course, the methods go in greater details, but I will try to point out the major aspects, which give you a general idea of the paper and what the aims are and how the methods and the patients have been selected. So being a retrospective study, patients get selected retrospectively. So these are all patients which already received ketamine at the time the study has been decided to be performed. So how do they do it? They basically fish for ketamine patients by doing a query of the hospital records, of all the hospital records for the emergency department, and they get queried by free texting the word ketamine, and then manually reviewing all the records that come out of this query search. And they do sort of a manual filtering of all cases to actually select those that received ketamine for sedation, for agitations, and not say for ketamine in the emergency department, ketamine as an abused recreational substance, and so on. And once they have selected these patients which receive ketamine for agitation in the pre-hospital settings, they do extract from the hospital data all the demographics, the patient history, the EMS and the ED observations, the airway interventions performed by EMS and ED, and the need for any other use of sedations or analgesia or any other drugs by EMS and the emergency department.
I will say, Luca, that I did find it interesting that they excluded a few patients because they had ketamine listed as a home medication. So I'm not sure who's prescribing that for home, but must be some very popular physicians back in the U.S.
Well, there is an intranasal spray version for drug-resistant depression. So my guess it could be that. I'm not 100% sure when it got approved in the U.S. But I think there is an intranasal spray, a ketamine spray, which is in use in certain countries. I've only seen it as a thing, but I don't know which country use it and which country have it approved. So my guess could be that could be one of these.
Interesting. I haven't heard of that. I'll have to look it up.
So they do filter out of in the study period, which is 28 months. They do filter 86 patients which receive pre-hospital ketamine for agitation. So in the study period. And out of 86 patients, the primary outcome is that 14 of them, which is 16%, received intubations once in the emergency department. Only one patient received the BVM ventilation throughout transport with a failed intubation attempt by EMS. The paper sort of describes, although poorly describes, the indications for intubations, because clearly, as you can see by these percentages, it means that patients were actually falling into multiple categories. So probably some were single category, some were multiple category, but it's unclear how many fell into different categories. But you can see that the most common indications were the need for feeling of airway protection, decreased GCS and respiratory failure. But from the paper, we cannot really tell what's the difference between respiratory failure, hypoxia, and hypercarbia. And also, what's the need for paralysis, the last indications? Because, of course, surely I don't think these were patients needed paralysis for their ARDS management. As Michael was saying, when we discussed this paper, myself and Michael, Mike was actually suggesting this might have been patients which presented with laryngospasm or airway compromise and needed sort of a paralysis because of either laryngospasm or bronchospasm, but it's unclear. The only thing which is mentioned in the paper is actually indication for intubation, need for paralysis. So interestingly, the total dose given as an absolute number or the weight-based dose does not have any correlation. Keep in mind, this is retrospective and this is a very small sample size, no difference in ketamine dose between intubation and non-intubation groups. And you can see that the average doses was approximately 330 to 350 milligrams. We are talking mostly about IM. 97.6% of these patients actually received intramuscular ketamine. The dose range between 50 and 600 milligrams. And it went from, interestingly, again, this is something very interesting to note, when it's actually per kilogram, it went from 0.74 to 8.80. And then another hint here is what is 0.74, in which range of, let's say, dosing are we? And was this given intramuscularly or intravenous? This is not something which is clear from the paper. Significant differences. So from an inferential perspective, they actually look at differences in patients' characteristics. And the only differences that they can find are actually the body temperature as measured between EMS and ED, between patients which are actually intubated versus those non-intubated. Increased body temperature is fairly common in psychomotor agitation. And decreased GCS. So those that got intubated presented with a significantly lower GCS than those that did not get intubated. No other vital signs from either EMS or ED demonstrated differences between the two groups of populations. And when breaking down the cause for agitation, so agitation was the big group, which, let's say, they included patients which received ketamine for agitation. When looking at the cause, let's say, quote unquote, cause of this agitation, was it primarily psychosis? Was it alcohol intoxication, drug intoxication, excited delirium, postictal confusion, or generic violence? They did not really find any difference, but we start with a total population of 86. So we're talking about probably 10 patients per group or less. So again, this is something to keep in mind when analyzing this paper. In the discussion, Mike, would you like to keep this discussion for later, right?
No, you just sort of you can cover the bit here, but we'll delve into sort of some of the more details around the clinical aspects of ketamine, I think, at the end of the two papers, if that's okay.
Absolutely. So very quickly, discussion points. Some of these are actually from the paper. A couple of these are actually just hints for discussions we can mention later. So the major, of course, discussion from the authors actually spins around that this study presents with a low, what they say, well, not low, what they mention as a considerably lower intubation rate than more previously published studies. So to give you an idea, this study position itself in sort of a lower range of the published literature, although, so there are studies which report a 63% intubation rate in patients receiving ketamine out of 135 patients. Again, quite small studies for the standard of like big randomized trials we tend to see today on major journals, but quite large studies for what is pre-hospital literature. 26% in a retrospective Australian study, of which I do not have the patient number, 39% in another study of 146, which was prospective. But we also find studies with lower intubation rate, the lowest being 4% in a population of 52 patients. They also go on talking about different comfort of provider with ketamine, so how much the A&E team is actually used to actually managing patients which are under sedation, not just analgesia, but under sedation with ketamine, and how comfortable they will be into ketamine assisting them while they're deeply sedated with ketamine. One thing is about how do we measure the sedation level. In intensive care, we do have sedation scales. Could they be more reliable than GCS? Many of the patients we see, we sedate with ketamine will present as a GCS of 3 or something very close to that. But that's, as we know, it's an artificial 3. But is it possible that somebody gets, allow me to use this term, scared by the GCS3 and decides that they need intubation? Would maybe a RAS, which is a Richmond Agitation Sedation Scale, which we commonly use in intensive care, be a better tool to assess these patients? And a couple of limitations, which I think we are going to talk later, but to keep in mind as a trigger point. There was no follow-up, long-term follow-up of these patients. And also the catchment area of this was just 2 centers. So there could have been a selection bias of other patients going to other centers or more specialized center, which were further down. For instance, providers unfamiliar with ketamine might have chosen to go the shortest route to take these patients to the nearest center, or the patients that they felt were unstable or at a risk of evolutionary, let's say, having an impending airway failure or something similar. And this could play a role in how this intubation rate is actually generated. So this is pretty much the first paper. My X's have disappeared here, but so this is the tool we use to assess, to critically appraise. This is the cohort study. It's just a series of questions that allow us to reflect on the paper. So if we have to say, did the study address a clearly focused issue? I would say, well, yes, because this is a clearly defined issue. They want to assess what's the intubation rate or the airway, the need for airway, advanced airway management following the administration of pre-hospital ketamine for agitation. So the study question is reasonably well defined. And the cohort recruited in an acceptable way. Well, as long as you define that this is a retrospective study and then you accept all the limitation of a retrospective study, the cohort was recruited in a reasonably acceptable way. We could discuss whether or not the interrogation of a free text in a database is an acceptable way. So I would have mixed feelings about that, but we need to keep in mind retrospective study, which often is the lowest in quality among all the cohort studies, which again are lower than quality than anything randomized. So we're talking about something which is methodologically reasonably well done, but which gives us very low level of evidence. The exposure accurately measured, and again, we're falling in the field of, was this extraction of data using free text reasonable? And we have limited availability here to actually discuss whether there was any patient that we missed because of this patient selection process. I think the patient reasonably discussed all the confounding factors, but there was no follow-up of the subjects because, of course, we only know what happens up to the ED and there is no long-term follow-up. Can the results be applied to the local population? This is an interesting this is an interesting bit. And I think these two questions, can the results be applied to the local population, and what are the implications of this study for practice to our, let's say, will this study inform our clinical practice, is one of the questions that Mike prepared for the end, for the discussion phase. So I'm going to just postpone these questions to later on. Just keep in mind these two questions. Can we apply these results to our local population, regardless of your role in the healthcare system? And what are the implications of this study for our individual practice? The second paper, we are...
Can we jump in just for a second
Yeah.
on that one? So thanks, Luca. That was a great review of the first paper. I guess we'll just take for a minute if anyone has any questions or comments about the methodology and the quality of the first paper. I think I just want to highlight the one point that you raised about understanding sort of the quality of evidence and the challenges of a retrospective data analysis or cohort, and that they did a good job for a retrospective cohort. But if anyone picked up so there's two things I always think about. So how could things have gone wrong in the study that might have given us results that don't mirror reality? And I guess the two things, one is the dose range, and those patients where they had doses down to about 0.7 milligrams per kilogram, which is down, certainly lower, and would be slightly higher than the usual analgesic dose, but it makes you wonder about, especially if it's IM, it would be very low. If there's a lot of those patients that receive lower dose and more towards the analgesia, not really sedation, that would make your denominator bigger, and they'd be less at risk for having a complication. So may make the study outcomes look better than if you had everybody who had a set dose at a high level. But the average dose is fairly significant. But we have to think there's some potential effect. I think the more interesting one was what you said in their line in there about that this is two community hospitals, but there is a larger regional psychiatric referral center, but it's a further distance from these communities. And you can imagine that, and this is what is different than doing a randomized control trial, where you capture the patients and you randomize at the point of deciding. You have an agitated patient, which treatment arm do you put them in, the ketamine or the control arm, and you follow all of those patients forward. If you imagine that in this community, say 200 patients actually had ketamine, and 86 of them went to the local hospital because they cruise for a whole variety of reasons, but may have been, it's closer, they want to get off shift, or more likely, because they're a little worried about them, they aren't as happy with their airway, something like that. And then the other patients all went, who they're much more comfortable with and are doing well with sedation and very stable, all went to the psychiatric hospital, which is a further drive away. You can see how this study at the small community center might have had a biased sample and over reported the incidence of airway complications, because you're selecting for those patients based upon distance and things. So just those are the types of things to keep in the back of your mind about this. Were there any other questions about that first study, just about the methodology or quality from anybody?
And another interesting bit, which is a very, very thing I find curious, is that between intubate, there's like a whole big table, which I've not presented. It's not very interesting, which compares a lot of vitals and a lot of ABG data of patients that get intubated and versus not intubated, but the authors do not present lactate, which I would have been really curious to actually see. And if I reviewed this paper, I would have actually asked them to actually see what the lactate difference was in this population.
Yeah, it is interesting they didn't do that, although I would say, and as we discussed, they actually present a lot of things in this table and a lot of analyses that really, they just don't have the power in the study to do the number of subgroups they actually did and the number of looks at all these different variables. So even if there was something there, I think it's a small underpowered study to find much more than their primary outcome.
Yeah.
Really, and even that, they don't actually talk about any power calculations to say what type of difference they would be able to detect based upon their sample size and things. So that there's a few little things about that would have been informative to know. But anyways, why don't we continue on and hear about this next paper as well?
The second paper, we are moving from a primary literature to a secondary literature. This is actually a systematic review entitled Ketamine for the Treatment of Prehospital Acute Pain, a systematic review of benefit and harm. So we are moving from the use of ketamine prehospitally for sedation to the use of ketamine prehospitally for analgesia. This paper has been published in 2020 as well. On BMJ Open. BMJ Open is open access journal, generalistic open access journal, so publishes a bit of any topic with an impacted journal with an impact factor of approximately 2.5 from the BMJ group. And as Mike was mentioning, one of the author of this systematic review has also kindly accepted to join us for this journal club. Again, I'm going to skip the introduction, which just gives the context about why prehospital pain management is important and the different possible indication and contraindication of ketamine in this setting. And we're going to just move on to the methods. So this is a systematic review, and that's where the author interrogates multiple databases available usually on the internet, with predetermined search queries, try to find all the literature that has been published, usually that has been published throughout time or since the inception of the search engine, which meet the predetermined search criteria, which is usually the topic of interest. Like in this case, we could say ketamine, analgesia, prehospitally, and then you combine these keywords, build a query, and then sort of see what you get and decide which paper really suits your purpose of being included, your inclusion criteria to be included into your systematic review. And then produce a paper which is basically a systematic comment of results of different papers, trying to address reasonably similar outcomes. So populations, this is an adult patients population, 18 years of age of older, with acute pain in the pre-hospital setting, receiving an intervention, which is ketamine. Ketamine, we shall precise an analgesic dose, which usually 0.1, 0.2, 0.3 milligram per kg. And this is compared, this is interesting because the comparator is actually quite wide. The comparison is done ketamine versus other analgesia, ketamine versus no analgesia, or ketamine given in combination with other analgesia, or ketamine given in different doses. And this is because there's quite a sparsity, there's quite a paucity, not a lot of literature on prehospital ketamine. So there are different comparison. Making a single outcome, single comparator was probably not sufficient to produce a systematic review. The outcomes are multiple. The primary outcome is of course pain reduction, but also some pharmacokinetics like speed of onset, the duration of the effect, and very interesting relevant adverse events. The author include all adverse events, although some of these might not have actually happened in any of the studies, such as mortality, morbidity, the presence of anaphylaxis, nausea and vomiting, hypotension, respiratory failure, loss of airway patency, or emergence phenomena, which is basically the agitations, or anyway, I would say agitation and delirium. So the first part is a bibliometric analysis of, they created the database. Through the database and through electric querying of this database, they have obtained a total of 1,197 paper, which were primarily evaluated by inclusion-exclusion criteria. First level is actually to assess them by title and abstract screening. These produced 61 eligible paper, and this was rerun by full text screening, so by actually reading all of the 61 paper. And in the end, 8 paper, actually 6 paper plus 2, which were added by adding paper which were referenced into the other papers, were found to be meeting the criteria. So a total of 8 papers were found to meet the inclusion criteria from the initially retrieved papers from the query. So this is 8 studies, including 2,760 patients. Interestingly, the author chose to do a systematic review including all available studies dealing with ketamine and analgesia in pre-hospital settings, regardless of the primary study methodology. So we have a total of 5 trials and 3 cohort studies. 4 randomized and 1 plus randomized trials, which account for approximately 600, well, not approximately, sorry, for 699 patients. 1 small prospective cohort studies, and as unfortunately often happens in these cases, 2 retrospective cohort studies that include the largest amount of cases, and this is because it's much easier to include patients in retrospective studies rather than in trials. The largest, it's worth to mention that the largest of the 2 studies included 1,876 patients and was actually conducted in war zones and was about delivery of war zone analgesia. Again, this is a quite well, I would say, methodologically well done paper, which accounts for a lot of the aspects that need to be taken into account in a systematic review. And so I will actually just give you a generic idea. It's actually a 22 pages paper, which I think, so I think I need to give you just a bit of the highlights of the paper, and then we can discuss later if there is any specific question. One of the things that the author do is they take their selected paper and they analyze them sort of for a source of bias. So they sort of provide judgment against predetermined quality criteria of whether the methodology the paper's author used was, we could say, sufficient or of good quality, to assume then that the results that the authors of each paper states are actually valid. And there are predetermined quality criteria, let's say, that can, and bias, and also sources of bias. And these are slightly different for randomized controlled trials and for cohort studies. And this is why you actually see them separated. So this graph actually presents different kind of bias, which are presented on the vertical section, the studies which are presented in the row section, and then the color legend is basically the systematic review authors rate these studies per bias, as they have in a high risk of being biased, an unclear risk, or a low risk. And the of course, and this, you can see, the other thing is you can read the kind of bias, just to give you an idea. If you're thinking about randomized control trials, the name says exactly what they are. So they're randomized. They can be randomized on different layers. But if we think about, does the trial have issues with random sequence generations? Like by reading the paper, can I clearly understand the randomization sequence generations? Yes, no. And this is basically how they filled out this table. Then they looked at allocation concealment. Was the allocation of the intervention concealed from patients, from physicians, from investigators, and so on? And is this clearly documented and understandable in the paper? And as you can see, what they conclude is that the main source of bias for randomized controlled trials, as it reasonably commonly happens in reviews, they find that it's linked to lack of random sequence generation, lack of allocation concealment, or lack of or blinding of patients, personnel, and assessors. And these are, a lot of these is often linked in pre-hospital care to the technical difficulties of delivering a trial in pre-hospital care, and to the difficulty of actually concealing an intervention in pre-hospital care, because these are aspects we need to think about the practical the practical difficulties of actually delivering such trials in the pre-hospital environment. Then I realize I don't have a slide, but I will quickly read this from the paper. The 8 included studies actually do compare different things. So this systematic review is sort of combinations of studies that actually have slightly different outcomes. They all use ketamine for analgesia, but they use ketamine for analgesia versus slightly different comparators. So there are different 5 comparisons. One is ketamine intravenous versus opioids, which could be morphine or fentanyl. One is ketamine intravenous and morphine intravenous versus only morphine intravenous, so a combination of 2 agents versus 1 agent. One study particularly is about ketamine, the mode of administration of ketamine. So ketamine intravenous given as a continuous infusion versus ketamine intravenous as a single dose. The 4th comparator is ketamine intranasal versus nitrous oxide, so Entonox versus Entonox alone. And the last comparator, interestingly, is ketamine alone versus no analgesia, or versus no medications at all. For each of these comparators, the authors basically present us with a brief description of the effect that the ketamine versus the comparator, let's say the opiates or the morphine or the Entonox have. And this is usually presented as a primary outcome in change of pain, which is usually measured either as a numeric rating scale or as a visual analog scale. But again, this is not very consistent in different studies. So some studies will use numeric rating scale, where you ask the patient, tell me how much is your pain from 0 to 10, with 10 being like the most excruciating pain, 0 being no pain. Or VAS, which are visual analog scale, which are actually scales where you would actually show the patient non-verbal scale of, let's say, expressions like smileys or things like that. Then the author present a forest plot of the effect of benefit and risk ratios between all these comparators. And here I'm presenting you some of these. Basically, what we can see from these, this is the first one that I've read to you, which is ketamine versus opiates. And specifically, we have one study which was ketamine versus fentanyl, and one which was ketamine versus morphine. And again, keep in mind, one of these is actually a randomized controlled trial, and one of these is an observational trial. The top part is about the effect, so the change in pain score, and the bottom one is about complications. Complications in these are actually nausea and vomiting and agitation. And you can see, how do we interpret this? We interpret, it's actually written below the forest plot. We do have a change in pain score, which means pain was lower with ketamine versus lower with opiates. And in the bottom, we see that nausea and vomiting was actually fewer with ketamine versus agitation, which were fewer with opiates. It's not mentioned here, but the paper also mentions that there were in the ketamine versus opiates, specifically in the fentanyl subgroup, in the fentanyl studies, there were 4 adverse events reported with respiratory compromise. 2 patients reported respiratory compromise, and 2 patients suffered hemodynamic instabilities, all patients being in the fentanyl group. There is no plot about this. This is textually described in the paper. This is the morphine versus ketamine and morphine. So this is morphine alone versus ketamine with morphine. And as we can expect, if we add a second agent, which is ketamine, the pain will be less, but the side effects will be more, because as you can see, there's few with morphine. And this is simply, my simple interpretation is when we're adding a second agent which has its own characteristic, chances of having a complication is slightly higher. And especially you can see nausea and vomiting slightly higher with the ketamine plus morphine. Then the third one, which I have an image of, is the ketamine and Entonox versus Entonox alone. And again, we can see there is less pain with ketamine plus Entonox, And there is also more side effects. But again, side effects are mostly nausea and vomiting in this population. So at this dose, adverse events reported by these systematic reviews are mostly few events, very few events. Most of these events related to nausea and vomiting. Only one study reporting increased agitations at analgesic dose, and one study reporting 2 respiratory compromise and 2 hemodynamic instability, but in the fentanyl group, not in the ketamine group. So the author concludes that low-dose ketamine can be safely administered in analgesic purposes during prehospital emergency care when proper indication and contraindication are identified. Although, and I agree with this, they also remind that prehospital providers needs to receive level of training suitable to administer ketamine, and that is usually the ability to treat potential complications, and as it often happens. And again, going through the critical appraisal skill, this time these are systematic review questions designed specifically for systematic review. Did the review address a clearly focused question? Well, I'd say yes, because of clearly the aim was clearly described. And the authors looked for the right type of paper. I think so. Do you think all the important relevant studies were included? I think the author did a good job in selecting all the studies. I think there is an issue linked to how many studies are available and what is the quality of the origin studies. Did the reviews author do enough to assess quality of the included studies? I think this is definitely yes. So they did a very good assessment of the study content, the study bias, and the quality of the grading of the quality of the evidence. If the results of the review have been combined, was it reasonable to do so? Well, this is an author choice, choosing which and how many studies to put together, although, as I said, they have quite different comparators one against the other. So these might make a bit difficult to interpret these data. And overall, we need to remember that systematic reviews, which are methodologically very good, will produce results which are, from a results perspective, of only as good as the data that you give to the systematic review. And the data to start with is, of course, as the author themselves say, of a medium to low evidence quality. So can these results be applied to the local population, and were all the important outcomes considered? I think these two questions will link to the discussion points, which are the same as we mentioned in the cohort studies. Can we inform our practice using this data? And is this applicable to our populations? I think this is part of what we are going to discuss.
Luca, that was great. Thanks. Why don't we just take a second, because since we have one of the authors here, and I don't know if anyone else has joined, Marius said he might try to join as well. But Bob, I think this a very well conducted paper, and as Luca said, I think the challenge is probably just what was out there to include in it. I'm curious to know if you had any different takes than we've said, and what's your next steps you are thinking about based upon this, based upon having conducted this paper. Are you still there now?
Yeah, I'm here, and I'll probably be off in a sec. But still, this was a part of a bigger project that was actually reviewing all the evidence for prehospital pain in Scandinavia and trying to get some good guidelines out. So this is a step in the guideline process. So that's probably the next step of patching out more reviews. Or did I get the question wrong?
No, that's great. I was curious as to whether or not you were. It's actually, again, it's fantastic to see that you're doing this as part of developing guidelines. I think this is certainly the type of work that should be done before care guidelines and practice changes go out. And it's you're certainly leading the way in Scandinavia with that aspect of pre-hospital care. I was kind of curious. Sometimes, a lot of times, certainly back in Canada is one of our sort of approaches to our trials, and from the critical care trials group is to undertake a systematic review before we plan or do a randomized control trial. So I wasn't sure if you were planning on doing any actual studies to answer more clearly any of the questions in this field or not.
I think that after the guidelines, there is a great many studies we want to do. And if they come alive, that's good. And if not, it's kind of generating hypotheses for next studies to do. As you're well aware of, pre-hospital studies are rare and far between. And some of them are half decent done, and some of them are not at all good for trying to get the evidence out. So, of course, it's a part of the generating for bigger studies and part of the guideline work.
That's great. Thanks. And thanks, Luca. So why don't we have about 10 minutes left. So why don't we open it up to the floor, and people who had some considerations, I've taken it off the presentation view, so people are welcome to turn on their videos if they want to, but you don't have to ask any questions and comments on your thoughts about this. Maybe I'll take the chair's prerogative of the last closing thoughts. I'll let everyone else dive in first. So anybody want to kick off? Harriet, Jason, you've both come off. Do you have any, either one of you had a burning comment to say about either of the papers, or how has this impacted, changed what you're thinking about either of these, or how you feel about ketamine, where we should be going, or what you'd want to do next to especially Harriet, as you're thinking about your next national study in the UK, what you might want to do?
I think Luca's comment about how we don't really measure sedation was quite interesting. It's one of those things we measure, we state our intended endpoint, but we don't really formally measure it in ED. And again, I think that kind of slight, it might be right, it might not be. Generally it is because people are comfortable with it. I think quantifying that is a really interesting question that we haven't really touched upon in ED stuff. But I don't know if that has changed. Luca, are you an intensivist or are you an emergency physician?
I'm an intensivist, but I have done some ED.
And when you go down to ED, how do you feel comfortable with how the sedation's on that, or do you find it's slightly uncomfortable in terms of the differing monitoring and the differing sort of outcomes and the different levels of sedation, as it were? And has this changed your practice of how you perceive that, or what you would do if you were doing one in ITU and one in ED?
Well, the interesting thing is that the scaler that I've mentioned, the RAS, has been designed for continuous monitoring of sedation. So this is more for patients that are, like, let's say, not 24 hours sedated, but sedated for a prolonged amount of time, and you need to quantify their level of either arousability. And actually the scale goes from negative to positive, because it goes from actually sedation to agitation. I was wondering, well, I've been wondering myself a lot of time when I actually do sedations myself in the pre-hospital environment, and then I write on my HAMS run sheet like GCS3, what does this GCS3 means? Because that's like an artifactual, or it's like a spurious GCS3, but I don't have a tool to actually say that the patient is sedated, but just not responding. Now GCS3 could be a bit like extreme in a sense, but often it's not a good way of describing it. For short-term sedation, Mike?
No, go ahead. I was just going to ask a quick question before we went on. Go ahead.
No, I'm not aware at the moment of any tool, but maybe if we did the literature research, and I don't know if Jake, which is very knows about actually a tool to assess sedation in the emergency department in the terms of depth of sedation.
I think Jason maybe want to answer. You were going to ask me the APPs what they're doing, but certainly in other practices, it's common to use a sedation scale to target your sedation. What are you doing in a?
So we're using the sedation assessment tool. So it gives you plus up to 3 or minus, depending what sedation is. So we do a post sedation and a pre-sedation assessment prior to sedating a patient. And it'd be just interesting to know on the first paper what other drugs they gave that may have caused the RSI. Did they give large quantities of midazolam? Were they quite free with midazolam? or were they giving antipsychotics like haloperidol or droperidol along with the drugs that they were administering? So it'd be interesting to know what their breakdown was of their sedation.
Yeah, I think Luca's looking at the moment, but they do mention in there, I think, the other drugs that were received or administered. Do you have an answer, Luca, or you? I think Keir has his hand up. You want to go ahead, Keir?
Yeah, it's looking at that paper. It's interesting to look at kind of some of the definitions about why patients are intubated, and certainly that one where 7 patients were intubated who are violent and combative, and that if someone is presenting in that kind of state, are they acute behavioural disturbance, or have they just intubated patients who are violent? It's a bit of a kind of, it's quite a broad kind of description, I thought. I thought my main thing really with the paper was around about the governance behind the sedations, really. And I think, is it probably the big question for me that this paper kind of posed was, are there complications being missed pre-hospitally by the drugs and then only being picked up in ED? Or is this then that something's happening at ED and then the patient's having to be intubated? And it'd just be interesting to know what the governance is behind, are these cases reviewed? Are all paramedics giving it there, which it looks like they probably are. So that was my kind of big thing that came out of this, really.
That's great. Thanks. Chloe,
I was just going to say, building on that, I think it's not at all unusual that ketamine is used as a precursor to intubation as part of a planned. Intubation is not necessarily a failure of the use of ketamine, but it doesn't feel like that study really tried to pull that out, especially in kind of agitated, delirious patients that are hyperthermic. They're often going to need to continue on to have a GA until they are flattened, I'd have thought.
Yeah, I agree. And I think this is one of the things about the underlying issues around a retrospective cohort is that a lot of those types of things aren't answered, and why it's better, sort of a more rigorous methodology can be better. The other question that you kind of wonder whenever you read any paper, and that's why I asked Bob as well why they're doing their paper, is, so why are you doing this paper? And especially when you get something like an ED review paper like this, you kind of get the sense that there's something that stirred them to ask this question, and that can be done with different motivations by different people. Now, it is interesting to note that the corresponding author for this, he went looked up, because I was going to see if we could get him to come, but it was just too timelines were tight in the time of day. I don't think it was going to work, but he's actually a paramedic who's gone on, former medical director, or was a paramedic, became a physician, emergency physician, and one of the medical directors at a different EMS, but not the EMS that he's reporting on. So you can read into some of these papers, is there something going on? Is there politics behind the ambulance service and the emergency department as to what's prompted them to look into this? Or the opposite is that, it could be that he's trying to quell concerns and say that this is good. So, but those types of things can always influence a degree the study as well. Anybody else? Karen, Sam, anybody who had Mike, any other comments or questions?
Well, Jason, I'm trying to find the drugs, but I don't think I can. I don't think I'm not succeeding in finding the intubation drugs in A&E for these patients. I don't know if there's a supplementary. I will look at. I will get to you about that.
Well, I don't think it was the intubation drugs. I think it was the other co-drugs with sedation, because they did mention in here that plus or minus midazolam being given with the ketamine. I think I'd read.
There's a table which says how many in the intubation versus non-intubation group received other sedative drugs.
It doesn't say how much or what. Yeah.
But I can't find how much or what.
Yeah. Just they just do mention midazolam somewhere, but as you say, I don't know if they actually gave the specific amounts. But that would be something that you'd want to you would be certainly reporting, and something if I was reviewing the paper, I would have asked them to include. because they should have that data if they have the other data. Rob, anything from your usual insights into pre-hospital care you wanted to comment on?
I think I'm good. Any questions that I can answer?
Okay, thanks. I was talking about, and Rob, our Rob, well, not ours anymore, now belonging to somebody else, but formerly, oh, he's already left.
Belong in the southeast of England. No comments at all. That was really nice done, Luca. Thank you. I've got nothing to say. Thank you.
All right, thanks. Well, we're getting close to the end, so I'll just wrap up. I think for me, these papers were interesting. So 2 different types of methodologies for different studies, both showing their strengths and weaknesses. As I said to Luca, I thought particularly the systematic review and having to take lots of different types of drugs to compare. So you can understand now why when they're doing guidelines and trying to get some sense as to which do we recommend between different options, but also there was usually when you do a systematic review, you'd find 5 or 8 papers that were small and underpowered on treatment A versus treatment B that you wanted to look at, and you get sort of a clearer picture. But this is sort of they're shining little pen lights and getting little pieces of the ketamine sort of puzzle that you could see through the systematic review, and a little bit more sort of clarity in terms of what seems to be a more focused question in the retrospective cohort, but potentially some significant methodologic issues. So for me, I guess my takeaway from this was, in terms of my current practice, I'm not sure it would change what we're doing right now. It would certainly make me think that there's some potential benefits for ketamine over other analgesics when used in isolation. So not, as Luke says, not combining, because then you just get the downsides of both drugs. In the analgesia world, that seems to be quite safe, and something that's probably could be looked at even further for practice. But they also don't compare some things. That they don't compare IV paracetamol, they don't compare Penthrax, some other things out there you'd want to know. And then in the IV the ketamine for sedation, I think certainly some signal that some red flags that make me worry, and that I'd want to see, as Keir said, really good governance in any process, but in particular, certainly really good follow-up and seeing what the outcomes are and having an audit process in place to see if there are potential adverse events. And the downside is that with an airway and hypoxia adverse event, sometimes that ends up really bad. So, what's your threshold for how many of those? 1 in 100, 1 in 1,000, 1 in whatever you're willing to tolerate in your service. So I think that's why the long-term outcomes are really important. I think obviously more data is needed. You can see for the analgesia one, almost like a more modern design, like a randomized adaptive trial that could try different arms with different therapeutic options and keep on working through to find the best combination of analgesia, ketamine versus opioid, ketamine plus something versus something else or whatnot. And then certainly I think an RCT for the sedation, because you really do need to compare to something such as ketamine versus haloperidol and a benzo, and really do a good head-to-head comparison to see what happens there. Anybody else let you have the last word, Luca, since it is your journal club? And thanks so much. This is a fantastic review.
Sorry, I was muted. No, I think this has been a good good journal club. Especially, I'd like to thank all the external, in the sense not from LAA guests that decided to join us. Especially with this is an process that we are starting to move, and it's good that we have different professions, different people joining and discussing something that we are effectively using every day on our patients, and try to better understand how to deliver the best care we can and have an effective also governance when using these drugs. I don't have much else to say. I think we have quite covered in depth, and I think if anybody has any questions or would like to talk more or discuss or develop any research project. Like Harry, I can see Harriet's already thinking about 2 or 3. You're more welcome to just send us an email or anything.
Right. And we're always open for future suggestions for journals, and happy to have people, our friends of LAA Lead Journal Club as well. So, and I'm going to be meeting with Rachel from LAS soon, and one of the things I'm going to be proposing is whether or not we consider these more of a joint endeavor and do things like rotate presenters and things. So we'll see what we can do. But yeah, everyone's welcome down the road. Thanks for taking the time to come. And Luca, thanks for a great job. So I'm going to stop there. Bye, everyone.
Thank you. Have a good one. See you soon.
Bye.
Thank you, guys. Thank you.